All right, thank you. Welcome, everyone. Thank you so much for being here with me today. I was sharing with Dr. Perez. This is my first time doing one of these, so hopefully it goes well. Hopefully you feel like you can walk away learning something. This is a passion of mine that started probably in undergraduate, to be honest. I am currently faculty at Nova Southeastern University College of Psychology. I wear a few different hats. I do three things. I supervise doctoral trainees. I am the director of our APA accredited South Florida Consortium internship program, and I teach classes for fun because I love it. That's probably one of my favorite things to do. So anyway, I have a lot of slides, a lot of material. I'm hoping that we can make this more interactive. So I can't see you, but we do have a chat. I'll ask a couple of questions. I'd love to hear from you. I don't think I'm an expert on this topic. I don't know if I ever will be. I don't know if the expert idea exists. I have a whole philosophy on that, but it's something that I want to learn more and more about every day. It's where my passion is. So let's get started. We're going to be talking today about working with children through a trauma-focused lens. So we're going to be covering a lot. My goal is to get to it all. If we don't, that's okay too, but we'll do our best. We're going to talk about trauma. I know a lot of us know what trauma is, but it could be defined a lot of different ways. So we'll start there on the foundational idea of that. I definitely want to integrate case examples. I feel like this really brings it to life and helps us understand what this can look like. And that's really what I want to get across today. We're going to talk about complex trauma. We're going to talk a little bit about ACEs, risk and protective factors. I know we've heard that a ton of times, but just to cover it again briefly, how do we assess trauma in children? And then hopefully, if we can get to it, my favorite part, we're going to finish up on resilience, trauma-informed care, and positive psychology. I would hope that you would be able to do all these things when you leave me today. Again, don't want to make any promises, but I am hopeful we can get to all of it. Okay, so let's start with trauma. What is trauma? Is it the same for me and for you? And actually, while I ask that question, I'm going to open up the chat. Okay, so at any point, I'm going to have it open and try to look back and forth because I really want to make this didactic and interactive. So is trauma the same for me and you? If we're all in a room together and a traumatic experience happens, is it trauma for all of us? The answer is probably not, right? So it's not the trauma itself, but it's the way it's perceived to be traumatic. And so my experience in that moment can be so much different than yours, and that's what makes it traumatic for me, but maybe not for you. What this experience does is it overwhelms that person's coping bucket. So it's something above and beyond basically what they can cope with, and this becomes maladaptive for them, or they have this trauma response to the event. I love to see that there's guardian ad litems here. There's psychologists, by the way, school psychologists, mental health. I'm trying to look and talk at the same time. Okay, so what is the impact of trauma? A lot of ways that it impacts an individual, and you can see them all listed here. All parts of a human are impacted when they go through a traumatic event. What I do want to highlight below is the three in bold and also the sense of self. So as you see, psychological, social, cultural, spiritual, it does a lot of harm. Ultimately, it harms that person's sense of self. And something that I want to connect to here and at the end of the presentation is someone's safety, their ability to connect, and their ability to cope. And we're going to talk about safety later, but safety is a primary need of all individuals. If you don't feel safe, you really can't function. And so I want to highlight that here. Okay, so we're going to get a little bit into acute versus complex. A lot of opinions about this, a lot of ways to define it. I'm going to talk about what I've seen in the research, and you might have a different idea, but I think it's all over the same concept. So acute trauma is something that's acute in its name. It's isolated. It's one single event, and I want to hear from you all. If you want to put in the chat, can you give any examples of what acute or isolated trauma would be? You might have heard the terms little t versus big T, type 1 versus type 2, all sort of the same idea. So acute trauma might be a big T or it might be type 1 trauma. And if you have any ideas of what those might look like, add them to the chat. Then there's complex trauma. So this is more pervasive and widespread. You might have also heard it be titled, yes, car accident. It's a great example of it, of an acute. Witnessing of a shooting, absolutely. Any others? Go ahead and throw them in. For complex trauma, yes, natural disaster is definitely one too. Complex trauma is more pervasive and widespread. You might have heard this be labeled little t's or maybe type 2 trauma. And if you want to add any examples of complex trauma here, please share. So overall, complex trauma, it's prolonged. It happens over a longer period of time. It could be repeated, okay? So we hear polyvictimization is a big word about that complex trauma idea. It's most of the time, if not always, interpersonal or relational in nature. And this is really important when we talk about the impact of this type of trauma. And we're focusing on children today, right? Children, adolescents, but this is typically during early periods of critical development. And this is so important when we talk about brain changes, brain development, and why that matters. So you might have heard terms like developmental trauma, relational trauma, chronic trauma. Those are all fair, but for the sake of the presentation, we're going to refer to it as complex trauma. For these individuals, yes, multiple traumatic events. Thank you for sharing, everyone. Abuse, domestic violence, gaslighting, emotional abuse we're going to talk about. Thank you so much for participating. So for individuals that have gone through complex trauma, these people are going to be in this constant state of alarm. They're going to have the HPA system, the stress response system is going to be activated a lot of the time, if not all of the time for them. And one of the other big things, again, I want to highlight is they're going to see adults as a threat. Okay. I really love this quote. I was reading it by Thane and his colleagues. In this article, they did a pilot investigation, a newer article, but anyway, they describe complex trauma as this. It's like shifting sand. Like it can be really dynamic and it could look very different. And you wouldn't want to miss kids. And I wanted to put that here and highlight that because I think this happens all the time. Complex trauma is so dynamic. It can look different for every single child, and I feel like they are missed. And that's my passion today, and my goal is to get that across by the time this PowerPoint finishes. I also really appreciated this diagram that they put. It was new. Again, it's a newer article. It's a pilot investigation, but they call complex trauma like chaotic bumper cars, which makes sense if you've worked with the children that has experienced complex trauma. At the heart of complex trauma, you see here, is the trauma itself and this relational disruption. If you remember a few slides prior, we talked about complex trauma is typically relational in nature. So a lot of times it's a parent, it's a caregiver, it's someone that they thought they could trust and they cannot. It ended up being someone that hurt them. So that's really important to note. So those two things interact. Then you can see the middle sort of circle here. We have internalizing and externalizing behavior. So ways now they're responding to this trauma. Then we talked about that sense of self, and that safety has now been compromised. That's a very big deal because it impacts their whole self. Yes, thank you, homelessness too. All of those risk factors we'll talk about later. Then they have regulation difficulties. This relates directly back to brain development. They are having a hard time. They're in that state of survival. And so they're having a really hard time using that upper part of their brain to regulate themselves. And so that is where you see a lot of these behaviors again that are problematic, but as a result of the trauma. Finally, you have these sort of perpetuating ideas that continue on with this child, and they're all interacting together. Remember, think about these chaotic bumper cars that are sort of like back and forth impacting one another. So we have systematic issues. If you've ever worked in a placement in a facility, a site where you have children that have experienced trauma, they might be in a foster home, they might be in a group home, and foster parents a lot of times are angels on earth and sometimes they're not, right? Sometimes the placement is not the best fit. Everyone's doing their best, but don't get me into the whole idea of our systems. That's another topic. But there's maybe instability in placement, poor treatment. So that's something to consider. And then the other part that's so important is they're having this lack of a counter reference. And so all they've ever known is someone that has been abusive to them, whatever that looks like, whatever that trauma is. And until they have a new experience, which we're going to talk about that later, how we can do that for them, that is going to be their reference point, and they don't know what else love can look like. I don't know if you've ever had this experience before, but I had a child that was in a foster placement. Foster mother was amazing, loved him with all her heart, did everything she could for him. And guess what? That little boy, his sole drive and his desire was to go back to be with bio mom and dad. Bio mom and dad abused him, but guess what? It was his bio mom and dad. And so sometimes having, like, they know that love, and it took years of this foster mom to give him this new experience and to not give up on him, for him to finally sort of accept this new life. And I think he'll always have that desire to go back with parents if he could. Okay. So I'm sure you've all heard of ACEs. If you haven't, that's okay too. But these are these adverse childhood experiences. And the reason it connects to complex trauma is, like we talked about, these traumatic experiences happen in childhood, which is in the title. And so these are the different areas of ACEs that we might see with our children. Abuse and neglect, some of you have mentioned that in the chat. It could be physical, sexual, emotional abuse, or physical, emotional neglect. And we'll talk about prevalence rates in a moment. Household dysfunction. You can read all those here. I can't see a show of hands, and you don't have to put them up, but I think a lot of us could probably connect to at least one of these ACEs listed here on this page. And we'll talk about why sometimes it impacts others more than someone else. I just wanted to put it up here for you to see it, but this is what an ACE questionnaire could look like. And so you mark, has this happened to you, yes or no, and then you add up the points to see how many ACEs that you've experienced. Now, just diving into prevalence rates very quickly, approximately 2/3 of US adults have experienced at least one ACE. So again, if we were all in a big room together and we were brave enough to raise our hand, probably almost half of the group, maybe not totally, would raise their hand, right? That they've experienced at least one ACE. However, about 17%, so approaching 1/4 of adults have experienced 4 or more ACEs. One thing I want you to know is when ACEs exceed 4 or more, the rate of depression, suicidality, other mental and medical health concerns skyrocket. So the most common ACEs they've seen are emotional abuse. Again, another fact about trauma is that emotional abuse, proven over and over in the research, has the most detrimental effects for children. If you want to share why you think that might be, I'd love to hear your ideas in the chat. The other most common ACEs are physical abuse and then household poor mental health. And then just looking at different demographics, looking at the diverse populations, females are known to have 4 or more ACEs, American Indian, Alaska Native individuals, multiracial individuals, and LGBTQ+. And so these are individuals, if you're working with them in your practice, you might want to think more about if they're susceptible or if they've been exposed to different ACEs or traumatic experiences. Okay, thank you all for sticking with me. It is not talked about often and no one sees it on the outside. Exactly, Jackie. It's hard to truly define, right? And it's one of those things where they're not being emotionally abused maybe all the time, but that's that inconsistency. One second they're berating them or putting them down, and the next second maybe they do feel loved. It's very confusing too for the child. Yeah, Allison, it is overlooked. It's hard. We can see a physical mark, but can you see emotional abuse? And you can't, right? So it makes it really tricky. Yeah, thank you so much, everyone, for participating. So, okay, why does all this matter? Well, it matters for a lot of reasons, but one of them is the effects on brain development. So this is what I'm gonna drive home today. We're gonna do a couple of cases in a moment, but trauma looks like something you may have all heard of, attention deficit hyperactivity disorder, also known as ADHD, because there's true neurological changes that are happening in the brain when a child is impacted by complex trauma. There's a TED Talk I'll talk about at the end of my slides, but you should definitely watch it. It drives this point home in a really nice way. But children are at greater risk for a lot of different reasons, but their bodies, their brains, their immune systems, hormonal systems, they're all still developing. They're so fragile, right? And so when they're experiencing these really traumatic experiences at a young age, it's impacting the way their brains are making connections. The ongoing development of a child, it really can end up impacting their DNA transcription, right? Down to their DNA, which is really powerful when we think about it. I was going to share, I don't know if you've ever seen the still face experiment. Maybe when you're done here, you can Google it and watch that video. It's about 2 minutes. But it's every time I watch it, I get tears in my eyes, but it shows a little baby that their mom is interacting, and then she turns and looks back with a still face, a stoic face, and the baby at first tries to laugh and giggle, and then they start to scream, and then they start to reach out, and then they get aggravated and start to cry, and then eventually in only 2 minutes they give up. And so again, I just share that to say that those, just the connection, having a depressed mother, having a mother that's neglectful or a caregiver that's neglectful. We don't recognize that emotional abuse again and neglect, how impactful it can be for a child. We can't really see it, but it can really have devastating effects where children just start to sort of dissociate and give up. Um, I saw that. Yeah, it's so upsetting. Everyone should watch it if you haven't seen it yet. Okay. So, symptoms of complex trauma. You can sort of see them all listed here. It will look differently for everyone. You might see issues with attachment. Maybe you see they have affect or behavioral regulation challenges. Their cognitive functioning may be impaired because of it. They can't form relationships, have low self-concept. All of these things you see, feelings of shame and guilt, and just their overall worldview might be distorted. You might have other associated features. Again, maybe you see disrupted eating patterns, sexualized behavior, even toileting issues, enuresis and caprices. Especially you might hear the term secondary, meaning maybe they were toilet trained and then all of a sudden they start wetting the bed again and having nightmares. Those are also like pink flags or like tall tale signs of maybe it's some trauma going on. So with that being said, what disorders do you think would be the most common if you were diagnosing a child that has experienced complex trauma? I'd love to hear from you. So thinking about reactive attachment disorder, absolutely. PTSD, depression, DMDD, ODD, separation anxiety. I love this. Yes. EBD presentation, emotional behavioral disorders in general. This is amazing, everyone. And I think you're driving my point home. You're all experts, see, that it could look like so many things, right? So we're going to talk about that now. Thank you so much for sharing. Borderline too, absolutely. Okay. Another question, maybe a little bit of a hot topic, but I'm going to go there for a moment. I know the DSM is our Bible, and I do give it a lot of respect, and I know that things can always improve and change for the better. That being said, can we argue that a single current psychological diagnosis in our DSM cannot account for these multifaceted clusters of symptoms associated with complex trauma? You don't have to say if you don't want in the chat, but think about this. And basically also, do you think that PTSD can adequately, consider the pervasive and developmental effects of chronic childhood abuse and neglect? And this is something we're going to get into, but I just want your mind to start thinking about that for a moment. Okay. Maybe you've seen this, maybe you haven't, but this is something I just wanted to stick on the slide to bring attention to quickly, this idea of developmental trauma disorder. So this isn't a current diagnostic a disorder, I'm sorry, in the DSM-5-TR. It is something that they're proposing maybe for a future revision. And I'm not going to go through all of it and read it. You can look at it later, but it basically is trying to capture what this complex trauma can look like for children. They involve here emotion dysregulation. They involve basically a lack of emotional literacy, being able to identify and even express their emotions, difficulty with attaching to others, maybe being aggressive. So I feel like it's trying to pull in a lot of these different diagnoses you just shared and put it under a label or a title where we're saying this is why all this stuff is happening. And it's not because they're truly oppositional, it's because they've had developmental trauma. So something that I'm in favor of, I should say a fan of, but not sure what you all think about it. Okay, so another question, assessment in children. How would you assess a child who has experienced trauma? What measures do you think you might use, and what considerations might you have with this type of presentation? If anyone wants to put in the chat before we go to the next slide. What do you think? What type of assessment would you do? House tree person, so some projectives, absolutely, thank you. Play therapy and drawing. Yes, the case ads. Developmental screeners. I love this. ACEs, there you go, right? We talked about that already. BPS, a biopsychosocial, is so important, right? Really getting a thorough history of the child, looking at their cognitive profile. Thank you all so much. I really appreciate it. A trauma symptom checklist. Amazing. Okay. Yes, PTSD measures. So Some ideas, you all are hitting them, so thank you so much, you're on it. But these are some things that you could do if you're working with a child where you're suspecting they've experienced developmental trauma. Maybe, well, not maybe, definitely do a comprehensive clinical interview. Thank you for sharing that. You would want to maybe do some trauma-specific tools. I just listed a few here that I've used in the past, but maybe if anyone has any others that, thank you so much, Dr. Loeb. Any other ideas of things that you can do, add it in the chat and take notes. Like I said, there's so much to learn about this topic. Definitely behavior observations. We want to, observe this child in the school and the testing session or therapy session, whatever platform you're using with them. Standardized questionnaires, maybe you do the ACEs like someone mentioned. You can do broadbands like a BASC or a CBCL, maybe a personality measure depending on their age. Collaboration is critical, right? With the caregivers, with the teachers. You want to still look at their cognitive assessment to develop, to determine where they are compared to same age peers. And then trauma-informed assessment. And this is so important. I was just talking to a student just a little bit ago. I don't think they're in here, but I'm going to call them out. But asking, how do I just approach a child that I know has had trauma, that doesn't want to share, that's shutting down? What do I do? And I said, just let them feel safe and let them know you're ready to connect with them when they're ready. And so no matter which you choose out of this list, or if you choose them all, please always go in with this type of trauma-informed approach where you're just being sensitive and letting them feel like they're safe and you're going to follow their lead on their time. I think that's really important. Okay, so let's get into a case. We have an 8-year-old Black female with a Haitian Creole background. She presented with difficulty concentrating, inattention, and hyperactivity at home only, okay? But that sounds like ADHD, right? She also presents with impulsivity and oppositional behavior at the home and at the school. And she's engaged in some bullying and being hostile in the classroom. So probably making us think about oppositional defiant disorder. Oh, sorry about that. Okay, so now looking at some of her scales. The one on the left is the teacher, the one on the right is the mom. Looking at all of this, if you want to put it in the chat or think to yourself, what stands out to you? And I'll point them out. If you go down the list, very elevated for the teacher is defiant and aggressive behaviors. Yes, she was fluent in English. Thank you so much for asking that. Really great question. Some social problems. Her violence potential indicator was at risk, rated a 60. Yes, absolutely. And then if you look down at the DSM symptom scales, they're endorsing ADHD predominantly inattentive type and ODD very elevated at a 90. Okay. And this is not surprising when a parent, a caregiver, a teacher is reporting on a child where they're having a lot of behavioral issues. We know we're going to see these things spike because they're frustrated, right? They've had enough. It's really difficult sometimes to work with these children. So it makes sense why it's at a 90. Then looking at the parent, they're not endorsing anything except hyperactivity, impulsivity, and under DSM-5 symptom scales, they're endorsing ADHD again, maybe some hyperactivity and ODD. Okay, so let's pause for 1 second. Are we done? Do I say this child has ADHD, maybe combined presentation or inattentive presentation and ODD? No, we don't. Okay, and let me show you this now. We gave the trauma symptom checklist. Everything was at risk, and this was for the mother filling it out because it was for younger children. Everything was at risk, and the post-traumatic stress arousal was clinically significant at a 74. Never done with just rating scales. I know, Dr. Kash, I learned better from you. So what does PTSD stress arousal mean for us? It might mean someone that's easily distracted, has a hard time concentrating, might be aggressive, might be hostile, may have an exaggerated startle response. And so this is so important to consider because all of that can sound like ADHD and maybe even ODD. So going back to this little girl, conceptualizing her when taking all of the things we did together. The ADHD symptoms were only observed in home. The diagnosis we know requires at least 2 settings or more. ODD was not diagnosed because we knew from doing a thorough background that she had unresolved trauma and difficulties with emotional processing. So she was acting out maybe that she couldn't express herself in any other way. And she had trauma exposure. So we know this can mimic ADHD symptoms. It can cause her to have hyperarousal and difficulty concentrating. And so we needed to follow up more. Okay, you're thinking maybe depression and PTSD. So she ended up meeting full criteria for PTSD. And I just want to break down for a moment, and you all seem like you are on it and know what to do, but just as a reminder of why these thorough assessments are so important when working with these children, because we need to look at so many different areas. She was sexually abused at age 5, so we know she has the trauma background. And the sexual abuse, so we talked about that acute versus complex trauma. This could be why she did meet PTSD, because though it was a very traumatic experience for her, it was more isolated in nature, that it was a one-time incident. So she was endorsing intrusive thoughts and memories, specifically when she was playing. So when we observed her, we did a play observation, and then they were reported having nightmares. She had distress when exposed to trauma-related cues. So the clinician was actually administering the child's apperception test, or children's apperception test, and they became very uncomfortable when there was an image of a child appearing naked on there. So that's again why these observations are so critical when working with these kids, to pick up on those little slight nuances that can tell the story. There was hyperfixation on sexual content. So this little child had discussion about boyfriends and private parts and their appearance. And so that seemed to be something that she talked about very frequently that was important for her. She denied it. So she was very resistant, overwhelmed, and uncomfortable about talking about this. And it makes a lot of sense because she lacked a lot of that emotional intelligence. She had a lot of irritable behavior and angry outbursts, but it was a lot of times directed toward the brother who was the perpetrator. She had an exaggerated startle response and fear across settings, and she had difficulties with self-esteem and excessive concern. The reason I put this here is because just looking at rating scales, like someone mentioned we never want to do, is going to give us a very invalid or misunderstanding of the child's presentation. It's so important to look at the whole child, do all these different things through testing, observations, etc., to really understand and get to the root of what's going on with this kid. Okay, I have another case for you all. This is a case that's near and dear to my heart. I'm going to try to go through it as quickly as possible. It's a lot of information, but this is a 14-year-old Black Hispanic male that was in the 7th grade. He presented with defiance, aggression, academic struggles, and these symptoms began at age 5. Important things I want you to know. About at age 7, he was experiencing nocturnal enuresis and nightmares about 3 to 4 times a week. Like I already mentioned earlier, we know that these can be pretty big warning signs for someone that's experienced complex trauma. He was initially evaluated in the 2nd grade, about 8 years old, retained in 3rd grade, so already now seeing some behavioral and academic issues, and he has a history of failing classes. The year before he was evaluated, he had 67 school absences, so labeled as truant. Going into his family and environment a little bit, limited contact with biological father. Domestic violence was in the home, and allegedly he was a witness to that. And just to share with you, he was identified as the leader of his friend group. And I think that's significant, and we'll talk about it in a minute why. In the past, he had a formal diagnosis of ADHD. Is anyone surprised? He had involuntary hospitalizations, Baker acted, for aggressive behaviors and violent behaviors, more risk to others. And he had interactions with the Department of Juvenile Justice. Okay, and if you have any questions about the case, you can put in the chat too. So just to share some observations, in the classroom, he appeared distracted with objects at his desk. He would talk back to the teachers or just flat out ignore them. He put his head down most of the time, minimally interacting with anyone, and he would at times just walk out of the room without permission. So if you hear these things, what does that sound like to you? If anyone wants to add in, I'd love to hear. ODD, exactly. ODD, conduct, right? This like oppositional conduct-like behavior. Thank you so much. So in the testing sessions, the testing observations, initially defiant and non-compliant, not surprising, right? Very much a slow to warm up approach. He would slouch in the beginning of testing, and then toward the end, about 4 sessions later, he sat up. He became more comfortable and confident as time went on, and something that I think was important to mention is in the beginning, he came in with sweatpants and a hoodie over his head, slouched down, really just not engaging. And the last session, he came in jeans and a shirt and really looked handsome and, really well groomed, which I thought was really important too. Yes, I know. It sounds like a lot of the kids you probably work with, right? Okay. I want to show you these. What stands out to you when you look at this? On the left-hand side column is one of the teachers, the English language teacher, and on the right side is the science teacher. Hyperactivity, aggression, conduct, all of the things were elevated for the most part on the left-hand side. And on the right-hand side, what is going on with the science teacher? We're going to find out in a second. Not really endorsing much, okay? He likes his science teacher. Okay, thank you. So then you see again 2 more reports. One on the left is the mother. Again, all of these things in the 70s, approaching 80s, everything clinically significant when it comes to externalizing. Same thing with the math. A 103 in conduct problems from the math teacher. That's really serious, right? Okay, so what was going on with this kid? These are some of the interpretations. So hyperactivity, aggression, conduct issues across the board. You can't really argue it, right? Reported by all informants with the exception of the science teacher. The science teacher noted an improvement in behavior over the school year. This child was able to eventually follow the rules and engage. And if you want to put in there, I know Dr. Cantrell, you mentioned, but why do we think maybe that happened with this science teacher? You mentioned that he liked her, her or him, I don't remember. But what do you think maybe happened with the science teacher? Science class can be more interactive, absolutely. And maybe they were more nurturing. You know, these children that are exactly, maybe he felt hope. These children that are so oppositional and conduct like, the first thing you want to do is not connect with them. And I'm going to give you a little anecdotal story really quickly. I'm going to try not to do this, but here I am. What before he was tested, the evaluator was told, be careful, sit with the door open, keep yourself close to the door. He has eyes that can kill. Basically saying like he's scary and no one wants to work with him. So imagine having that reputation. Who's going to want to connect with him and give him a chance? So let me go back to where we were. Projective measures. So someone mentioned house, tree, person, family in the beginning and other projective measures. So important for someone that on the face value, or what something is so obvious, he's not going to share, right? So he's not going to come out and say, I'm so angry, I'm anxious, I feel hopeless, of course, right? This is a protective mechanism for him. But through the projective measures we saw, he had anger, he had aggression, so we saw that, anxiety and hopelessness. And he recognized anger more. Why? Maybe it was modeled in the home for him. Anger is more of a reactive, like id reaction, right? If you will, something that just he's learned over time. He hasn't really learned how to come through those reactive impulses to control his emotions or identify it, right? And through also projectives and other tests, we recognized he had poor self-concept. He was emotionally guarded, which we figured, and had uncertainty about the future. Yes, thank you for all the comments about science. Okay. So conceptualizing this boy that I like to call Martin, he had truancy and school refusal, which was hindering his academic performance. He was struggling with his peer and adult interactions because he didn't know how to regulate himself, and he had basically no coping skills. He was aggressive because this was a part of his emotion dysregulation, and again, something he witnessed and learned in his home in early years. So I have it here, but we would recommend for him a multi-systemic approach. You know, we want to connect the home, the school, and the community for this child, but he needs wraparound intensive services for years to make a difference, because now he was 14 years old, I believe, 14. Yes, and having all of these struggles. He needs the trust, the unconditional support, and a safe environment. I want to share one more quick story, and we're going to move on. But this individual toward the end, I mentioned, was wearing jeans and a shirt, was feeling really good about the testing, even engaging voluntarily. And he was promised if he finished all the testing, he would get a pizza. So he finished all of his testing, and as promised, he was asked, what type of pizza do you like? And he got a cheese pizza. When the cheese pizza was brought to him, he said, hey, do you think I could bring this to my classroom and share it with my friends and my teacher? And not me, well, maybe it was me, but basically started to cry, felt so touched, and not something you would ever hear from someone that you were told looks can kill, right? If he can kill with his eyes. So he wanted to share this pizza with his peers. He was feeling, I think in that moment, hopeful. fast forward a couple of weeks, and this kid did something not appropriate. Did some sexual gestures in front of peers, peer influence, having to keep that leader role, and really was not being respectful in the moment to the evaluator when they had formed that relationship. The evaluator tried to address the behavior in a way that was maybe authoritative, like giving, like, you can't do that, but also I'm here for you. He did not like that at all. He did not like that at all. I think the trust was immediately broken. I think the defenses shot up and the relationship was ruptured. And it's such a sad story. Whenever I tell that story to my students, they're like, really, that's the ending, and even worse than that, ended up dropping out of school, and being on the streets. Again, not great, but it's the reality. And I only share this to say this is a kid that was experiencing complex trauma at age 5 and earlier, right? At age 5, he was showing signs. And why at 14 was he still not getting the support that he needed? And this is where my passion comes in. And I feel like the early intervention and intervening with these kids at a young age and giving them that different experience is so important. And I wish that I could have impacted him in other ways and made a difference, but hopefully it was a little bit. But yeah, it's a sad story. It's the reality, but I think it really paints the picture of what this could look like if it goes untreated. But there's always hope, and I think that's also in this story too. Exactly. Really hard time accepting the feedback, right? Because they're defensive and they're on guard, which is understandable. Okay, I think we're doing okay on time. I do have one more case. I'll try to make it quicker. But I wanted to talk about a 9-year-old white female. And so same sort of presentation, it, was presenting with hyperactivity, couldn't sit still, excessive talking, but also was very disinhibited in how they engage with others. So would run up to an unfamiliar adult, hug them right away, didn't really check back with caregiver. We didn't know a lot about early experiences. All we can say was that there was some unknown details about the first 12 to 15 months of life, and where there was suspected insufficient caregiving and lack of emotional needs for this child. So limited opportunity for securing these attachments earlier on in that 0 to 12 or 15-month period. She ended up being diagnosed with 2 things. She was diagnosed with ADHD and disinhibited social engagement disorder. She met criteria for both. I don't know, hindsight, maybe it wouldn't have been this way, but this is what she met criteria for both. She was impaired in both areas, and this is what she was diagnosed with. Let me stop before I go to the next slide. When this report was presented to the school in a school meeting, what do you think everyone focused on? Yeah, the ADHD, which shouldn't have been surprised, right? But here we are writing up all this description of why, yes, now it is showing as ADHD. It is impairing in multiple settings. It is making it hard for her. She really could benefit from different behavioral techniques, and she needed to be in individual therapy to address this trauma history, family therapy, etc. And all they looked at was the ADHD. Really frustrating. And again, not to be a Debbie Downer here, or so negative, but just to really point out that this happens all the time. And I want, again, you to leave here knowing these things. I'm sure you already maybe did, but reminding you to please know this. If this is something you do in a report, or if you're working with a child, advocate for them and share that one diagnosis because you can see it or because it's more problematic does not take precedence or is not more important than the other. I see it actually as the reverse. Because like it says down here, that symptoms will be misinterpreted as a neurodevelopmental disorder rather than that trauma response that it probably is. Okay, thank you all for sticking with me. So risk factors. I just want to put this here just to kind of segue us into the next part of this presentation. So we know that everyone comes with risk and protective factors. Some have more of one than other. And just want to point out that there's there's pre-traumatic risk factors, right? And so depending on someone's demographic variables, their resources that they have internally or externally, any type of pre-trauma psychopathology or pre-trauma life stress, all these things can put someone at higher risk for responding worse to a trauma. Then we have the time of the trauma. How was the perceived threat? Was it more severe in nature or was it more mild? What type of trauma was it? And did they have dissociation during the trauma? These are all type of risk factors during that time of trauma. And then post-trauma. different risk factors. I do have asterisk here, the social support, and I really want to emphasize, and this will lead us into the next conversation. Social support has been found in the research to have a negative association or relationship with PTSD, meaning that the more social support an individual has, the less chances they are to meet full criteria for PTSD. Social connections are so important. So SES is socioeconomic status. Thank you so much for asking that. I apologize. So these are all risk factors that a child would have, right? Pre-trauma, during trauma, and after. But they're protective factors, right? And so we hope that all children have both. And this is another part of the BPS. I feel like sometimes we might not think to ask or think about it in this context of what are these protective factors for a child. So it's at different multiple levels that might be their own individual protective factors, like having higher intelligence, being able to regulate themselves better, having more pro-social skills. It could be within their family. Again, we talked about family and social support being a really strong protective factor for individuals experiencing these trauma symptoms in the community. Okay, so why am I telling you all this? Because everyone in this room can be a trauma-informed individual, whether you're a professional, whether you're a caregiver, whether you're a teacher, a counselor, psychologist, whomever you are, you can make a difference and practice trauma-informed care with the children that you work with. Okay, so trauma-informed care, what is it? We're going to dive into it now, but I want to give you a couple of quick points. First of all, treatment of children with complex trauma itself is going to be complex and long-lasting. You heard with the case of Martin, that I like to refer to him as Martin. He needed a lot of care and love and support for a long period of time to really make a difference in his life. Not saying that those little moments didn't impact him, but he needed that to go on for a while. Toxic stress, complex trauma can absolutely be buffered by these stable and supportive relationships. What you do with that child can and will make a difference. And it promotes the understanding of a caring relationship. If you remember way back when we were looking at that diagram about a counter reference of a relationship, a healthy relationship, you not only will give them these other parts of trauma-informed care, but you can show them what it's like to experience a healthy love, right? A healthy care, a healthy attachment. Okay, so you may or may not know where this comes from. I'll show you the reference at the end too. But this is something that Dr. Bruce Perry and Oprah Winfrey talk about a lot in the book that they wrote together, What Happened to You. But I want you to think about this shift. A lot of times we hear about all these externalizing behaviors, all the things that these kids are doing to annoy us, to push us away, to aggravate us. And it's like, what's wrong with this kid? If you can, and you can tell anyone that you work with, if you hear anyone say that, let's try to reframe. Let's try to shift that from what's wrong with this child to what happened to that child. What happened to that child and how did that impact that child? That's going to immediately bolster that empathy and understanding and sort of puts on our guard to be open to working with this child more and to have more patience with them. So again, instead of saying, what's wrong with you, what happened to you? How did it impact you? And I think that's so powerful and something I really wanted to emphasize here. Okay. Trauma-informed care, to me, is simple. To me, it's simple, but it's one of the most powerful things I've ever learned about. There's 3 pillars that this article in particular talks about, but I think it's recurring in the literature, and it's sort of all saying the same thing, but we're going to talk about them now. The first pillar is safety. So I don't know if you remember in the beginning, we talked about sense of safety, sense of trust. These things are gone when someone experiences complex trauma. Think about a child that's in a home that this is supposed to be their home where they're safe. And if you listen to this TED Talk I share about, Dr. Nadine Burke Harris talks about the bear comes to their house every night. The bear in the woods that you would be afraid of, that bear's coming home every day. Every day they're afraid of what's going to happen. Am I going to get hit? Am I going to be put down? All of these things, right? And so safety is number 1. And this is something that we can do for all our kids. We can make them feel safe. Just to think about it, it's a core developmental need of all humans, specifically also infants, right? So starting at infancy, a child, a baby, a human needs to feel safe. It's a primary survival need. Think about when The hunters were out there looking for food. They were worried about surviving and living and not dying, okay? They needed to be safe. This is something we all need to feel. These kids do not feel safe, and that is so profound. It's the first psychosocial crisis of trust, if you want to look at it from a psychodynamic perspective. If you've ever heard about Harlow's monkey experiment, it was something that was done, I think back in the 60s, 70s, if I'm not mistaken, but maybe not ethically great now, but used some monkeys and wanted to see what monkeys would go to. Would they go to a wired sort of mother figure that had food, or would they go to something that had no food but had comfort, like a terry cloth? The monkeys most of the time would go to the terry cloth unless they went to get food very quickly, and then they went straight back to the terry cloth. Kids want to feel safe. Absolutely. Thank you so much, Dr. Cash. Um, the result of feeling unsafe, it makes them be something called adult wary. Okay. So again, are you going to hurt me? Are you going to make me feel unsafe? How can I trust you? And this is something that kids with complex trauma experience will have this. This is sort of the way they approach the others in their world. They're overly defensive. They're defiant to assert control. How many times have you heard of this idea that they're going to push you away before you push them away? They're going to hurt you before you hurt them. It's a protective mechanism to keep them safe because they have felt unsafe in the past before by caregivers and adults. So what can you do? It's truly as simple as being a safe space for them, being predictable, being consistent, being calm. You see the attributes that you might embody if you're trying to do this type of intervention. Let them make decisions when they can. Let them feel like, let them feel like they're in control or they have some power when in all of their younger life, they had zero control and zero power in what was happening to them. Don't be punitive. Don't be controlling. This is going to only reinforce what they've already known. Give them clear expectations. Let them know what to expect. What is the routine? When transitions are happening again, so they have that predictability. They are always sort of on edge. They're always wondering what's going to happen next. And this is something that I feel like we can all do. Someone asked in regards to trauma, how has COVID-19 impacted children? The experience of the uncertainty and multiple loss of loved ones. It's a really good question. I think COVID-19 has come up. I think even the idea of perhaps like school shootings have come up, right? All these things that are newer for our children. I have to be honest, I don't have any research in this moment to express how I think it's impacted them. I think it all goes back to the risk and protective factors. How was the social support during that time? How did they understand what was happening? What type of pre-risk and protective factors did they have, and how was it dealt with after? I think all of that makes a big difference, but we know that COVID-19, the pandemic, made a big difference. That's a sort of a global trauma that all of our kids have gone through. Okay, the next pillar, and I see the time is ticking, so I'm going to go a little quicker. The next pillar is connections. And so again, remember, we've talked about this. They associate adults as negative. Why? Because they've had negative interactions with adults. They feel suspicious, they avoid, they are hostile. This is how Martin was expressing himself during the interaction with the evaluator. So be a positive, have a positive connection with them, be a caring adult for them. This can create twice as much positive change as any therapeutic technique. I'm going to repeat that really quickly. Positive connections with caring adults are crucial, and they can create twice as much positive change as any therapeutic technique. We've seen in the research that the therapeutic relationship is so important, and you don't have to be in therapy. You don't have to be the therapist of that child. You can just be a neighbor. You can be a teacher. You can be whatever caring adult for that child, and you can make a difference in their lives. And to me, again, that's so powerful. Don't take it personally. There were the teachers that probably rated Martin at 100 when it came to conduct behavior that took it so personally when he swore at them or maybe stormed out of the classroom. It's his defense. It's his way of coping. We can't take it personally. And I think that takes a lot of self-reflection and again, educating ourselves and having knowledge on why are they doing what they're doing, not what's wrong with them, but what happened to them and how it's impacted them. And so that's going to again boost our empathy with them. Give them new positive emotions and experiences. Just be an alternative attachment figure for them. Again, show them that they can be safe with an adult. Finally, managing emotions. We know mostly all of these children that have experienced complex trauma cannot regulate. And that's where they look like they have ADHD, right? They look like they have oppositional behaviors. They have a really hard time regulating their bodies from a neurological standpoint. So, and self-regulation, as you see here, is a fundamental protective factor for healthy development. So this is where we're going to get into teaching them how to manage their emotions, their impulses. You can change this part of the brain, so that's hopeful. All of these things, these children can be resilient, which we're going to conclude on in a minute. So keep that in the back of your mind. This can make a difference for the kids you work with. You're going to want to label emotions. Help them problem solve. They don't know how to problem solve. They don't know how to use that higher order thought process to think through things. They're reacting. Help them be in the moment, be mindful. And I have a really awesome book about this that I can share at the end too. The PowerPoint, I don't know if we can share the PowerPoint, but we will definitely have this recorded. And thank you everyone for all of your questions. I saw someone else say, there's a quote that says, the people who need the most love ask for it in the most unloving ways. That is the most, I love that quote. That's so beautiful. It's so true. Okay, so we have less than 10 minutes left about. So let me think what I really want to touch on here. Positive psychology, it's like a whole other presentation, a whole other topic. If you haven't looked too much into it yet, or you want to learn more, I highly suggest doing it. I think it's such a great philosophy, such a great theory. And Dr. Martin Seligman is sort of known as the father of positive psychology, though there's a lot of other psychologists out there that study it. The reason I bring this into my presentations is that idea of resilience, of hope. I shared to you all, this has been a passion of mine for as long as I can remember in this field. One of my first experiences was I volunteered at the Boys and Girls Club during undergraduate schooling. And then I ended up loving it so much I stayed on as an art teacher for the summer, which I had no experience in art, but I just didn't want to leave. These kids really impacted me. But I remember sometimes I'd leave after a day of volunteering or work and feel hopeless myself and think, how can I help these kids that have all these risk factors, and I can't go home and I can't feed all of them and I can't protect all of them. Like, what can I do? And that's when I started learning a little bit more about positive psychology. And what positive psychology can do is it can really change that person's subjective lens of their life. It can give them hope for the future. Basically, you cannot change their immediate environment at times, right? Like, we know if you work in a school, you do all you can, and then they end up going back home to that environment. But what we can do is give them little nuggets or seeds of things that will hopefully continue to foster and grow resiliency, right? Plant these things that will be a part of who they are and that hopefully it will help them in their future. So with all of that being said, I sort of covered resilience, that all children are capable of adapting to their environment and developing this resiliency. And resiliency is the response to adversity. They can increase their gratitude. Simple things like just asking them when you see them, tell me one thing you're grateful for today. And you can tell them, draw a picture of that, tell me about it. Just that tiny little comment and having them engage in this very simple activity can almost immediately increase mood, satisfaction, energy. It can decrease negative affect. Hope is an antidote for at-risk children. Hope makes them feel hopeful for the futures. There's a lot of different ways you can do hope, but one of them at the bottom is called best possible selves. Again, please take note and look this up when we leave. It's something simple that you can do with all of your kids, but you basically ask them, imagine yourself in the future, the best version of yourself. What does that look like for you? Tell me about it. Draw about it. Again, it gets them outside of today, outside of that negative perception, and it makes them feel like, okay, maybe one day I can be a teacher. Maybe one day I will be a basketball player. Maybe one day I can be a doctor, or maybe one day I'll have my own home. Things that they can just try to get out of their everyday. Optimism, again, that's something as simple as tell me 3 good things that happened to you this week, or tell me 1 good thing that happened to you today. Again, just trying to change the way that they're thinking and giving them that subjective and internal control over how they're feeling and how they experience the world. I know it can feel Pollyanna, and we're not going to change everything they're going through. But again, if we can just give them a little bit of nuggets or plant some seeds to give them hope for the future, to me, that's really powerful, along with everything else. Okay, so sort of to wrap up, there's another quote. Let's read it here. For yesterday is but a dream, tomorrow is only a vision, but today well lived makes every yesterday a dream of happiness and every tomorrow a vision of hope. Thank you so much. I love that. Very cool. Thank you. So sorry we rushed through that, but again, if you want to look up positive psychology and if you want to look up PERMA, especially positive emotion, but all of these different ways that we can increase resiliency or positive emotions for children, having them feel engaged. We've heard ideas of flow. Again, I'm going into it and I shouldn't, but look this up. It's really powerful working with children with complex trauma. So I just want to end on this. If you have never seen the TED Talk by Dr. Nadine Burke-Harris on how childhood trauma affects health across a lifetime, please watch it. If you've already watched it like me about 15 times, watch it again. She does an amazing job of talking about the neurological changes that happen to a child when they've experienced trauma, and she's just an excellent speaker. What happened to you if you haven't read this book? Read it. If you've read it like me, but probably forget things all the time, read it again. This book by Dr. Bruce Perry and Oprah is amazing. If you listen to Audible like I do, they are the ones that talk about it. So it's really cool to hear it from their own mouth, what they've been through and what they know. So a really great book I recommend. And then the last book, I wanted to add it on here because it's an oldie but goodie. It's something I found in graduate school, but it's called The Whole Brain Child by Dr. Daniel Siegel and Dr. Tina Payne Bryson. But it really teaches children emotional intelligence, emotional literacy. What do I mean? It's like talking for baby. It's teaching children that have had complex trauma, that have never learned to say, I feel sad. I feel it in my body because of this reason, and this is what I can do for it. These children don't have that. It makes me think of another case I don't have time to talk about, but read this book. Super easy, super short read, but if you're working with children, this is an excellent book you can apply to all of your cases, and you can teach parents and tell parents to read it too. Thank you. That was a lot of words in about 56 minutes, but any last questions, thoughts, comments before we wrap up? Thank you all so much for participating. I can't see your faces, but I felt like we were still together, so I really appreciate that. Thank you. Thank you, everyone. Thank you so much for being here with me today. It's amazing. Any questions, anything else? You have my email, I believe. So reach out for anything. I hope that you enjoyed it. Thank you so much and have a great rest of your day.